And an absolute pleasure to talk to you about a subject I know very little about. In fact, I'm talking to the experts here, which is unusual. But nevertheless, I think, stick around. I do have some ideas on how to actually move the needle in terms of the treatment of rare bleeding disorders, taking the leaf and learnings from our current experience with hemophilia. These are my disclosures. And the agenda is essentially to introduce the concept of non-factor therapies and the unmet needs, and give you some indication of the latest results on that, and make reference to rare bleeding disorders, because I think it's opportune for us to start to look at the indications and applications of these therapies, and then perhaps and see how the non-factor therapies may change our paradigm of treatment in rare bleeding disorders. I don't have to, for this audience, remind you that we're talking about a fairly large number of conditions. Many of you, in fact, are experts in the treatment of these conditions. And you can see here that they range from fibrinogen deficiency to factor 13 deficiency, and a range of other conditions that some of us, in fact, don't have experience in treating. And I'm going to use hemophilia as an anchor to indicate what kind of treatment possibilities and paradigms could be available for these conditions. Just to remind you, for those who are not familiar with hemophilia, that it is bleeding into the joints, predominantly leading to chronic synovitis, leading to arthropathy, and of course joint dysfunction. We don't have a similar picture in many of these rare bleeding disorders, but what we do have in common in many of these rare bleeding disorders is that they bleed. They may not bleed into the joints, but they bleed into various tissues, and in fact one can have a handle on that. And the one handle we've used very well in the context of hemophilia is replacement therapy. We can actually prevent bleeds. In other words, treat this condition prophylactically. There's no reason to believe that the rare bleeding disorders cannot be handled exactly the same way. In other words, one could look for the replacement for the missing clotting protein, whatever the clotting protein is. And particularly exciting, I think, is, and you've seen this slide in my previous presentation, is this unprecedented therapeutic landscape and in hemophilia. We obviously do not have a similar picture in rare bleeding disorders. And perhaps the reason I'm showing this is, keep in mind that whilst this is very much exciting for hemophilia, hemophilia does have a number of limitations in terms of the replacement therapies. We have the peaks and troughs, and it doesn't really matter whether you're using standard half-life or extended half-life products. In fact, the troughs are the areas of the greatest vulnerability. So for the rest of the rare bleeding disorders, if you're thinking about the replacement therapies, just bear in mind that you'll be learning the same lessons that we are learning from hemophilia, that the troughs, in fact, are the greatest enemies in our therapeutic effort. We are battling in hemophilia to achieve optimal bleed control and to increase the number of individuals who do not bleed at all, the so-called zero bleed rates. The zero bleed rates in the latest extended half-life products, and I've summarized it here, is less than 50%. And if one looks at the real-world data, in fact, it talks of even a worst-case scenario of about only a third of the patients actually achieving zero bleed rates. So whilst you're thinking about what would be the therapeutic advantages of replacement therapy in rare bleeding disorders, just bear in mind that it is possible that you may not reach the therapeutic high goals that you set yourselves, as we have learned with hemophilia over time. And perhaps more importantly, replacement therapy doesn't stop bleeding at all. This is a series of studies. These are real-world data from the Thunder and the Head study showing that even patients on prophylaxis with replacement therapy, they do bleed. And they bleed, in fact, to the level where they damage the joints. And similarly, in the context of rare bleeding disorders, I want you to keep that in mind, that if you do have a therapeutic agent, it is possible that you might still encounter complications relating to the bleeds. And in fact, in the context of hemophilia, we do know that the bleeding leads to arthropathy, an impaired joint function, and it affects all joints. It really is not selective as to which joint is going to affect. What I would really want to introduce here is the concept of replacement therapy for rare bleeding disorders, bearing in mind the limitations of the replacement therapies that I've just pointed out to you. We are in an extremely exciting era in the bleeding community, in that we have a large number of these molecules evolving over time, starting with the mimetic proteins. In fact, the mimetic proteins have had several phase 3 studies completed. The antithrombin small molecules, in fact, the studies were published early this year. The monoclonal antibodies directed against the tissue factor pathway inhibitors are equally important, and I'm only going to mention two: the concizumab, which was published about a week ago, and mestacimab, which is currently, in fact, in phase 2 studies, going to phase 3 studies. And very early in the development is antibodies against the activated protein C. These molecules are important not just for the treatment of patients with hemophilia. In my view, they are actually agnostic to the bleeding phenotype. In my view, they should be able to treat all bleeding diatheses, including patients with rare bleeding disorder. And in fact, I just want to give you examples of how effective they are. When we do replacement therapy, there's no doubt in my mind that all of us are familiar with the complications associated with replacement therapies, amongst which is finding the veins. Veins may be difficult, they may be destroyed, infected, and thrombosed, and that applies across all bleeding diatheses. And in the non-replacement therapies, by and large, are actually given subcutaneously and not intravenously, so they do have an advantage. This is an example of how many times one has to inject replacement therapy in hemophilia when you're taking prophylaxis 3 times a week. By the age of 20, if someone is very adherent to therapy, you would have injected into these veins 3,120 times. You'll agree that veins were not meant to be injected that many times, at least not in human beings. It is my view that if we shift our mindset towards alternative way of giving these drugs, it will make a huge difference, particularly across all bleeding disorders, including rare bleeding disorders. Professor Tripodi touched on the concept of balancing or rebalancing hemostasis. We do know that replacement therapies are characterized by peaks and troughs, and it really doesn't matter whether one is using standard half-life products or extended half-life products. And what you really want is a consistent hemostasis that do not have peaks and troughs. And the non-replacement therapies, in fact, we have seen it in the context of hemophilia. They do not have peaks and troughs. And I have no doubt that many of these non-replacement therapies will be suitable for rare bleeding disorders if applied to the rare bleeding disorders with the understanding that they will provide consistent hemostatic protection, as you can see here on the right. Just examples of the kind of efficacy outcomes that one would expect for the non-replacement therapies. This is data from the phase 3 emicizumab efficacy data. There are about 8 phase 3 studies that have been completed in emicizumab. And the typical example in inhibitor patient, we're talking about 87% reduction in annualized bleed rates. And in non-inhibitor patients on the right, we're talking about 96 and 97% reduction in annualized bleed rate. And I have no doubt in my mind that if the mechanism of bleeding in the rare bleeding disorder is mediated through thrombin generation, one could expect similar results when one is using, of course, the factor 8 mimetic, where the factor 8 is deficient or, in fact, is required. If you move on to the other non-replacement therapies, such as the fitusiran, an antithrombin molecule, this data was recently updated actually in the publication in Lancet and Lancet Hematology, published early this year. It is agnostic to the phenotype of the bleeding disorder in terms of hemophilia. And I would want to argue that it's probably going to be agnostic to the bleeding phenotype of any bleeding disorder as long as the bleeding is mediated through thrombin generation. You can see the data here. In fact, one is looking at hemophilia A and B with and without inhibitor, and the reduction in bleeding rate is impressive. It's very, very much significant. And I want us to start to think along those lines, that for the rare bleeding disorders, it is time for us to start applying this concept across the bleeding spectrum rather than restricting them to the bleeding diathesis. And the one that was published in the NEJM last week, many of you might have seen it, is the concizumab. The data, again, very impressive, self-explanatory, very high efficacy in the reduction of the bleeding in patients who are receiving prophylaxis with this concizumab. By the way, concizumab is an anti-TFPI that is given on a daily basis. You might think that it adds to the treatment burden, but for some of us who are actually participating in the study, patients prefer it that way. In fact, the compliance is much better than having to give it every maybe 2 weeks or every month, because they may forget that they've given it again. And again, concizumab or any of the anti-tissue factor pathway inhibitors may well have some efficacy elements in the context of rare bleeding disorders. It's something that you need to start to think about over time. And the biggest limitation, of course, in many of these is the fact that we are not able to achieve the new goals in the treatment of bleeding diathesis. In hemophilia, we are managing to break through that ceiling of only achieving less than 50% zero bleed rates. And that is the evidence from the Haven 1 to 4. And that is actually a comforting thought that one could apply these concepts to rare bleeding disorders and achieve much higher goals than we can currently achieve with replacement therapy. And of course, joint resolution and the most difficult joints in hemophilia, as you know, are target joints. I've no doubt that in the rare bleeding disorder space, there may well be places of where the bleeding is actually difficult. And with this non-replacement therapy, one can only hope that in fact will have a similar impact in refractory bleeds and bleeds that are difficult to manage. And I want to take on the concept of an evolving goals in the bleeding disorders. Up to now, we've been thinking about treating patients with bleeding diathesis only from the point of view of stopping the bleed, and in the case of hemophilia, preventing joint damage. The non-factor therapies give us the potential to allow our patients to have normal activities of daily living, but more importantly, to have their lives that are very close to the lives of patients without bleeding diathesis. And that is my hope, and in fact, that we should develop the relevant tools to be able to measure that over time. It has been very difficult up to now to get the right tools to be able to evaluate the quality of life of patients. And in fact, it will also allow us, the non-factor therapies in the bleeding diathesis space, it will allow us to fully comprehend and implement the care delivery model. CARE stands for, in reality, the clinical care, the advocacy, education, and research that we need to do. What we have done up to now, almost exclusively, is the clinical care of patients. We have not had the opportunity to advocate effectively. We have not had opportunity to do research and limited opportunity to do education. And I'm hoping that, in fact, by this evolving landscape of non-factor therapies across the bleeding diathesis, we'll be able to move on to the next stages of hemophilia, of bleeding disorder care in our environment. And perhaps the single thought that I want to leave you with is the concept of a mindset shift from disease categorization as measured by the deficient clotting factor or protein to a phenotypic categorization as we understand it. In other words, bleeding and the severity of bleeding. The limitations of a disease categorization approach is that when you look at some of these rare bleeding disorders, in fact, it's sometimes very difficult to measure the protein that is missing, unless you work in a very specialized environment, such as Professor Favaloro and Professor Tripoli, who are experts at measuring these proteins. But in a routine setting, they may well be difficult. And it might be prudent on us in the bleeding community to start thinking of the evaluation of these patients in terms of the phenotype, the clinical outcomes, and the life goals that the patients would want to achieve, as opposed to what they need to, in order to stop the bleeding. Some of you might be following an exciting conversation currently at JTH, where we are proposing that, in fact, we need to reclassify the bleeding disorders over time, and we're getting exciting reaction for a number of quarters within the community. With that, in fact, I want to summarize, and I hope I've shown you that there are a number of unmet needs in the current replacement therapy in the treatment of rare bleeding disorders. And in fact, the non-replacement therapies have evolved in order to address some of these unmet needs, and they actually apply across the board of all bleeding diatheses, including the rare bleeding disorders. And I've shown and shared with you the data, at least from the clinical trials of the non-replacement therapies, that indicate that they are very efficacious in preventing bleeds, and in fact some of them are agnostic to the phenotype of the bleeding disorder. And it is my hope that they may well be repurposed in the near future to be used across a range of rare bleeding disorders. Non-replacement therapies, in my view, represent a paradigm shift in the management of the rare bleeding disorders. With that, I would like to thank you for your attention, and I'm looking forward to the question and answer.